Give me something else we give epinephrine for, Colin.
Anaphylactic.
Okay, give me something else that we use epinephrine for, Bob. Okay, yeah, mainly in kids, absolutely. Okay, and then racemic epi, obviously, we're gonna give racemic epi for.
Asthma.
Okay, thanks someone. Okay. Croup, asthma, absolutely. Okay, dopamine. Used to increase renal perfusion, increase rate and force of myocardial contraction, and constrict peripheral blood vessels. When you guys have this medication, you're going to get 3 separate doses, okay, that you're going to have to know. You're going to know your renal dose, you're going to use your contraction dose, and then your peripheral vascular dilation dose. So you're going to have 3 different doses you guys are going to have to know. And the interesting thing about that is pre-hospitally, we do use it quite often. We toss up between dopamine and dobutamine a lot down in Delaware County. Do you guys happen to use it a lot up here or no? Dobutamine, are you guys dobutamine people? No?
Nope.
None? Not a whole lot? No drips? No drips at all? We do a lot of drips. Yeah, we do a lot of drips. But dopamine and dobutamine are the 2 that we tend to use a lot. Albuterol, obviously, what do we use albuterol for?
That thing with the bees.
Oh my God, what is this? OMG, it's a beta blocker. Okay. We absolutely use it to slow our heart rate, decrease chronotropic angina pain, and to decrease irritability of the heart. So anything that's OLOL is going to be a beta blocker. Okay, so when you look at someone's med list, you're going to take a look at that. But we do use beta blockers pre-hospitally. We absolutely do. All right. So obviously our body is going to try to maintain a constant blood pressure. And then obviously our blood pressure is influenced by cardiac output and resistance of the arteriole. So blood pressure equals cardiac output multiplied by peripheral vascular resistance, or PVR. PVR. Okay. Are you good, Bob? Okay. So just shut up like what?
PBR.
No, not PBR.
Oh,
It's different.
This is disgusting.
seriously.
Whoa. All right, whoa. A couple people are giving you some dirty looks.
PBR? All right, why don't we drink a beer like Magic Hat or something?
Oh, for heaven's sake. All right, so body balances flow resistance to maintain a stable blood pressure. The issue is this. If you take away one component of what makes up your blood pressure, you change it, our body has to compensate by doing something else elsewhere. So we have to change a different variable. So cardiac output equals blood pressure divided by peripheral vascular resistance. So if I'm going to change one of those, if I change my cardiac output, I'm going to have to also change my peripheral vascular resistance, okay, to maintain that normal blood pressure. Does that make sense? So you have to maintain that balance. If I take one away from one side, then I've got to add one to the other, or I've got to take it away from the other. We've got to maintain that balance. Our body is in a constant fight to maintain homeostasis. So let's talk about assessing these patients, okay? Let's talk about common complaints. You got your chest pain, which we call what? What's chest pain?
Angina.
Angina, absolutely. And you have 2 forms of angina. You have stable and unstable angina. What does that mean? Does that mean my patient's unstable? If they have unstable angina?
No.
Not necessarily.
It's unstable if they have chest pain or rest.
There you go. That's the big difference.
That guy.
Unstable angina is only considered unstable if they are resting. They are not doing anything and they still have chest pain. If you have someone who has angina from shoveling snow, like I did this morning, that thing was just, it was a sheet of ice. But anyway, from shoveling, then you're going to have, that's stable angina. If it's unstable, I'm sitting. Dyspnea. What's dyspnea? My husband has bronchitis.
Ain't nobody
Ain't
got
nobody
time
got
for
time for
that.
that.
Ain't nobody got time for that.
Yeah, he is sick. All right, dyspnea. What's dyspnea? Shortness of breath.
He's probably dyspneic.
Yeah, dyspneic. Fainting, palpitations,
Syncope.
fatigue. All these things are indicative. Obviously, you're going to make sure you're seen as safe. You're going to anticipate the need for other resources. What other resources are you going to need for these patients? Bolt, yeah.
Lift assist.
You might need a lift assist. You might need, and these are all things that you have to consider because no one's going to start coming to help you until you
Especially
call
if the
them.
patient's 300 pounds.
That's
And
right.
if they're short of breath, the first thing you want to do is call for help.
Listen, that is like an open wound right there, just like salt. Okay, look for clues to identify the potential problem. Obviously, we're looking for clues. We always look for clues. Form a general impression, observe general appearance. Our cardiac patients, what are they going to look for? We talked about it right from the beginning. They could be obese. We're looking for patients who have a sedentary lifestyle. Our smokers, people with multiple medical issues. We're looking for apparent life threats. What would be a sign or symptom of an apparent life threat? You walk in and you're like, holy crap, they're going to die.
They're gray, no?
They're gray. What else?
Serenity.
They're
Really,
profusely diaphoretic.
they can't speak.
Dyspnea to the point that they can't speak.
Peripheral cyanosis.
Peripheral cyanosis, okay. Thank you. Altered mental status. You have to think mentation. That's obvious. Sometimes it's obvious. If they're unresponsive, that's a change of mental status. Okay, that's obvious. What else? Guys, give me some signs. Obvious life threats. Come on, kids. Could be cardiac.
Major hemorrhage.
No, cardiac.
Tachycardia.
Slouch down in a chair. Well, obviously, you'd have to take a pulse for that.
Right.
Profusely diaphoretic, we said ashen or change in color, skin tone. Obvious respiratory issues. What about audible breathing? Okay, if they're fluid filled, congestive heart failure, where you have a pink frothy sputum coming out, that's a cardiac issue. Absolutely. You hear them, you hear the rails as you walk in the door. That could be indicative of a heart failure situation or a cardiac issue. Determine their level of consciousness. How am I going to do that? Hey, are you okay?
Talk to them.
Hey, yeah, because if you walk into my house and say, hey, are you okay? I'm going to say, get out. But yeah, absolutely. Hi, my name's Danielle. I'm a paramedic. How can I help you today? Or if they're a frequent flyer, what? I get that a lot too.
What now?
That's a shame. What now? I hate when medics do that. We're here all the time. Well, you're here one more time. Go. All right, airway and breathing. Determine if the airway is patent. Check open airway for rate, quality, and effort of breathing. Consider oxygen therapy. What about oxygen therapy in these situations? Let's talk about administering oxygen because you have people still giving oxygen at 100% concentration to patients who are like 96%. And then they'll say to you, but they're cardiac. Weigh in. Talk to me about that.
If they have increased respiratory effort, then it's appropriate.
Right. So what's their are they stable? Don't just arbitrarily give oxygen, because you have people, medics, who are still giving oxygen just completely arbitrarily because it's a heart issue. Well, I have chest pain. Okay, well, automatically get oxygen. No, we don't do that anymore. Why?
Because of free radicals.
Because of free radicals. Absolutely. We don't want to cause issues by administering too much oxygen. So yes, it is damaging. Obviously, we're checking for a pulse. We're looking for, if they're conscious, we're doing a radial pulse. If we can't find a radial pulse, we're going carotid. Why are we not going femoral?
Little personal.
Hey, whoa. Whoa. That's not what I called you for. Unconscious. Obviously, we're going to do carotid pulse. Now, this is actually an interesting thing because this is where we change when we're talking about circulation. We're looking for rate, regularity, and overall quality. When our patients are on the monitor, we're looking for it to sync up. That's a new thing that we weren't doing when we were paramedic or EMTs pre-hospitally. Now we're paramedics pre-hospitally, and we're looking for that monitor to sync up. What I see on the monitor should be what I feel with my fingertips. If it's not, there's a problem. Okay? And again, what am I seeing on the monitor that should correlate with my pulse? The QRS complex. Good. Which is what kind of contraction? Ventricular. Very good. Okay. So we're going to assess skin color and condition. Transport decisions. So this is the issue. We got to first of all figure out if we have to immediately transport them, but then we got to figure out where we're going to take them. Now, what do we have to start thinking about with these patients?
Cardiac.
Cath lab. And then not just a cath lab.
24 hour.
Not even 24-hour.
The hour that you're available.
Interventional 24-hour cath lab. It's not enough for a hospital to have a cath lab. It's not enough for them to be open 24 hours. It's got to be interventional. Did you know that they're legitimately in Pennsylvania, up by Hershey? There's a place that just does diagnostic intervention 24/7. I'm like, but wait, you're not interventional? They're like, no. okay, good talk. Like, why wouldn't you? Well, whatever. But anyway,
Those are for the walk-ins, right?
I have no idea. But they're not so the word that you need there, that qualifier, is interventional cath lab. Interventional. That got to be interventional cath lab. Okay. If you're not sure where you should take this patient, keep assessing until you can figure it out. Okay? And I'm not saying just stay and play. I'm saying get in the back of the truck and start heading the direction you think you might need to go, and then make the decision. You can always change, if you're not completely, almost at the hospital, and then you deviate like 17 miles down the road. Don't do that. But you can get the person loaded and make those determinations and continue to assess your patient. So often we have chest pain as a presenting symptom of an acute myocardial infarction, or AMI. Okay, obviously we're going to do OPQRST, and we're going to start the process of trying to determine what the heck is going on. So when we're talking about a myocardial infarction, talk to me about the onset. What do we want to ask specifically?
Or not?
How long has this been going on? When did it happen?
What were you doing?
What were you doing? Because that could be the difference between stable and unstable angina, right?
How did it start? Was it gradual or was it sudden?
Okay, good. So what was the onset? Was it gradual? Did it come over the last couple days? What is immediate? What's going on? What about, I have a tearing sensation in my chest. Is that an MI?
Oh, no.
What might that be?
Oh, shit.
It's an oh shit. What is an oh shit? Yeah, absolutely. But it could be a dissecting aortic aneurysm, right? And what's going to
Was it
save me
back?
then?
Surgery?
An act of God. Yeah. If you're actively dissecting, you're going.
Surgery.
Yeah. Yeah, a very skilled one too. Absolutely. So quality, what kind of pain is it? Typically it's like a heaviness. People tell you that it's a heaviness. It's like someone sitting on my chest. It's a diffuse heaviness. It comes down to my abdomen maybe. Does it go anywhere? Where does it go down?
Arm.
Which arm? Left arm.
Usually.
Good. Okay. Or
Lower back,
neck, jaw, back, shoulder blades, all that stuff. Absolutely. S.
Severity, 1 to 10.
I mean, it depends on the person. You know what I mean? You have someone who really has not experienced a whole lot of pain versus someone who's had 17 kids. If you're treating Mrs. Duggar, chances are her pain level is going to be her tolerance is pretty high. And then T.
Time when?
When did this start? All right, dyspnea is another chief complaint of acute situations. So the first indicator for left-sided heart failure, when did it start? Suddenly or gradually? We already did all this stuff. Do you have a cough? That's the other thing that's kind of different in this. Do you have a cough? Does it hurt when I push? Okay, cool. So if I'm pushing and I get pain,
Probably not quite.
it might not be cardiac, but am I still going to treat it as cardiac until proven otherwise? Yeah, because every medic can tell you, like, dude, it hurt when I push, and they're having a massive MI. Okay, but also, I mean, you also have to use some common sense because, you're a medic and your adrenaline's all up and you're, like, forcefully pushing with your fingertips. Yeah, that's not comfortable. You know what I mean? So, again, you got to think about these things. Fainting. So, listen, you're going to faint when your cardiac output decreases. All right? You're not going to have the blood that you need carrying the oxygen to where you need it. It's just kind of common sense there. So under what circumstances did the fainting occur? Were there any warnings? Did you get dizzy and then pass out? Oftentimes, we're called for a syncopal episode, and we get here and we put the person on the monitor. It's like, holy crap, you're having the big one. Whoa. Okay? So they didn't call for chest pain. They called for a syncopal episode. Or my personal favorite, I fell out. What did you fall out of? Where did you fall out of?
Listen, I gotta say this. There was a call at the Sunoco the other day. I had to screenshot it because we get it on our phones too. And it said, a caller is acting a fool. I swear to God, I have it on my phone. I took a picture of it. It was awesome.
Acting a fool.
Yeah, caller states the female is acting a fool in quotations.
Awesome. Fun dispatchers.
It was awesome.
My favorite.
Know exactly what acting a fool means in Norristown.
Yeah.
Wild out. It's crazy.
Fell out.
While out.
We had a patient that
Wasn't that a show?
had a near syncope and his friend was
Wild
like,
Out.
"Oh, man, she fell
Wild
out.
Out, wasn't
We
it?
fall out. We
Yeah.
fall out the tree, off the
Listen.
roof, at the car.
Listen, when I first started my ride time, I was 18 years old, and I got it in the back of a truck, and this guy was like, I fell out, and I was like, where'd you fall out of, sir? What happened? And the medics could not, like, they were wetting themselves, they were laughing so hard. I'm like, I don't understand what's so funny. He fell out of something. What did you fall out of? How'd you hurt yourself? What hurts? And really, the guy was saying that he had a syncopal episode, and I was just like, oh, okay. So, under what circumstances did it occur? Were there any warnings? What position was the patient in? Did they fall from a standing position? Now we got to start thinking about C-spine. We got to clear their C-spine. Is this common? Okay, people faint. Some people just faint. Some people just. My sister is 24 years old. Listen, do you?
No, they go to the goats. The fainting goats, they just like fall over. Have you ever seen them?
Anyway, moving along. So anyway, so the patient have they fainted before? Is there a glucose issue involved? Are there associated symptoms? Is there dizziness? Palpitation is a sensation of abnormally fast or irregular heartbeats. We get called for palpitations quite often. It's often caused by some form of a dysrhythmia. You're going to ask about onset. How frequently? Is this a common thing? Have you sought treatment before? Do we know what causes it? Talk about previous episodes. What did they do for you last time? Well, last time they gave me adenosine. Okay, your palpitations are caused by supraventricular tachycardia or SVT. So they gave you adenosine to fix that. And how you know the dose of adenosine? No, can I tell you the dose of adenosine? It's 6 milligrams and then 12 and then 12 adenosine. It just works. You guys will remember that forever.
6, 12, 12.
But my way is so much more cool. Sorry, it is.
6, 12, 12.
6, 12, 12, and then adenosine. Whatever.
Have you ever been to Hamden in Baltimore?
No.
Okay. You sounded like straight out a Hun from Hamden.
Straight out of Boston.
I don't know. My sister-in-law is from Boston.
No.
She's got like that Boston flag stuff, packing the cat. All right.
But they can be on albuterol with palpitations, right?
Oh, okay, so let's talk about albuterol. Medications can cause palpitations, absolutely. People who have just given themselves a shot out of the EpiPen. I feel like my heart's going to beat out of my chest. I'm sure it does. People who just did a line of blow often will call you because they're having palpitations.
What's blow?
Cocaine.
Really?
What?
We did this.
I don't remember that.
Just like making
That was a
cool
movie,
weed.
right?
Yes.
Oh my
It was.
goodness.
It's
Anyway.
Basketball diary.
All right.
A lot of that.
So,
I love the rest.
patients might also report feeling
need
of
repetition.
impending doom. I feel like I'm gonna die. I know, and they do say that all the time. But you know the ones that are looking at you with wide eyes, they're profusely diaphoretic, and they look like they're gonna die. Chances are, if they look at you and they say I'm gonna die, and they're profusely diaphoretic, and their vitals are in the crapper, they're gonna die. They're gonna die.
Him and I had this guy one time, probably like 2 or 3 years ago, where I was actively giving this guy aspirin, and all of a sudden I'm like, and he's driving. He'd just given a report over like class 2 to where we're going, and then I was like, shit, Ian, make that class 1. He's like, I already saw it. I saw the look on your face, man. And I was like, all right, let's go.
What the
Got
hell is a
coded right
class
from-
1?
Cardiac arrest.
What?
We don't have classes.
What?
We're classless down in Delco, okay? We don't have classes. I've never
Class
heard
1
that.
through 5. That's what we
Nope.
transport with. Well, I'm sorry.
I don't know.
1 through 4, we don't transport class 5.
All right, well, anyway, long and short of it, feeling of nausea and having vomited, and obviously you want to talk about a medical history. Medication for patients with cardiovascular disease. Listen, they are going to have like pill boxes upon pill boxes, your cardiac patients. They're going to have shoe boxes full of pill bottles. You know, some of it's expired, some of it's not, some of it has labels, some of it doesn't. It's crazy.
I take one.
Yeah, but I had a medic tell me one time, sometimes you won't see ST elevation until after they throw up. It's like as soon as they throw up, you can see the ST elevation.
I've never heard that before, but I'm going to...
It's just probably bullshit. It's okay.
Well, I'm not saying it's wrong, I've just never heard
No,
it
that's
before.
what she said. Sometimes you'll do the 12 lead, it'll look normal. You'll be driving down the road, don't throw up.
That might make
Next thing you
sense because they're lacking more oxygen right after vomiting. I mean, that could be, I don't know that you're
She
going to
said
see
that,
that
I was just
immediately,
curious.
but I don't know. I truly don't know. Patients may be taking a wide variety of meds. You can't always identify the issue based on the meds, but that doesn't mean don't look. You always want to look at the meds. DIG preparations, listen, people on DIG, like, they can have a multitude of issues, and it's very difficult to see what's really going on with these folks. Chronic congestive heart failure patients, or certain dysrhythmias use chronic digitalis. These people are going to have increased cardiac contractions. If they're toxic, it's not uncommon. 30% of these people are going to become toxic, and they're going to have DIG toxicity. And for us pre-hospitally, we have to have a high index of suspicion for it to really identify what's going on, because these people present with multitude of issues. Oftentimes, we're going to actually see ditch toxicity primarily by looking at their EKG and looking at their med list and putting 2 and 2 together. Okay? We'll be sensitive to calcium preparations and have declined in serum potassium levels. So, again, for us pre-hospitally, we're not going to see those things, but we're going to have a high index of suspicion that this is in fact what's going on. Anti-anginal agents, so nitrates, tablets, ointments, skin patches. You will go to nursing homes and you will find people who have multiple patches all over them. Duragesic patches for medications and nitro paste that people just don't take off and they'll just keep slapping them on. And then they call you because their patient's bottomed out. They're hypovolemic or hypotensive rather. And you're like, they're like, I don't know why they passed out. And you lift up their shirt and there's like 17 different patches on them. I'm like, no. So again, you want to have a high index of suspicion for these patches and remove them. So the nitrates are going to decrease the work of the heart. And that makes sense because it's going to take away some of the pressure because it's going to dilate your vessels. So if I dilate the vessels, I'm decreasing my preload, right? So if I decrease my preload, then I'm going to decrease the pressure that my heart has to deal with. Onset's 3 to 5 minutes, and it's going to cause significant vasodilation. Obviously, for our patients, what are we going to ask before administering nitro?
Big Viagra.
You take Viagra, you take any vasodilators.
Or if they've taken any nitrates already.
Did you take any nitrates already? Beta blockers. We talked a lot about beta blockers today. Decrease the rate of strength of the cardiac contractions may lead to resistance of beta-stimulating agents. So again, for us pre-hospital, you want to have a high index of suspicion that our patient might be taking a beta blocker if they're really hypotensive or their heart rate's really low and it shouldn't be. We're going to start looking at that med list. Calcium channel blockers. Block the influx of calcium ions through the cardiac muscle. It also relieves angina. Hypotension is a common side effect. So if we have someone who's really hypotensive and recently switched to a calcium channel blocker, it's going to be something that we might want to look at. So these patients really in supportive care until we get to the hospital unless we have to do like urgent interventions. Antidysrhythmic agents control chronic cardiac rhythm disturbances. We have to monitor these folks very, very carefully. Some of the generic names that we see pretty commonly, amiodarone is cortisone, DIG is Lanoxin, lidocaine is xylocaine, and procainamide is Procan or Pronestal. Okay, so again, those are the medications and their trade names so that we know what we're dealing with pre-hospitally. Those are medications you absolutely have to know because we see them a lot. We really do. Diuretics are used for chronic fluid overload and hypertension. It's going to help excrete sodium and water. It's also going to excrete more potassium. So because of this, our patients may become depleted, and you might have a situation where they start getting electrolyte imbalances. Some people get to the point where you can see those electrolyte imbalances just by looking at their EKG. So you're going to start seeing ST segment changes, T segment changes, and P wave changes. It doesn't usually affect the QRS complex unless it's in an advanced stage. And when we get more into the dysrhythmias, we're going to talk a lot more about the morphology of the complexes and waveforms with regard to how different electrolytes are going to change them. Hypertensive agents are obviously used to treat hypertension. Here's the issue with these medications. They're really difficult to regulate. So they kind of have to play with people's medications until they get something that works. Anyone who's dealt with high blood pressure will tell you. I mean, it really does take time. They actually may cause hypotension while they're trying to get that sweet spot of what's going to work for what patient. And obviously you want to check the blood pressure in both recumbent and sitting positions. Why is that last part really, really important? Orthostatic hypotension, what does that mean, Kat? If you have positive orthostatic or positive tilt, meaning you have a decrease in blood pressure and increase in heart rate from one position to the next, it may actually indicate that the person is hypovolemic. So if that's the case, it's something we can fix pretty regularly or pretty easily pre-hospitally, right? What do we give them? Fluid. Easy.
I have a question about that.
Sure.
So if you know that they're hypertensive and on some kind of hypertensive agent or
I'm sorry, I can't hear you. Speak up.
If you know that they're on some kind of a hypertension medication, you typically would not want to give them any kind of fluids, right? But then if they're also hypovolemic, then you're going to, but you're going to increase their pressure.
So your person who has a history of high blood pressure is hypovolemic. So they're still going to be hypotensive. Just
Right.
because someone has a medical condition like hypertension chronically doesn't mean that they can't crash. So you're still going to treat their low blood pressure as the end result of that. Okay. For us pre-hospitally, I don't know if everyone heard that. Did everyone hear that okay? For us pre-hospitally, we're more concerned with emergent care, but we do have to think about long-term care as well. And that gets into the situation where I have a patient who has high blood pressure. Hopefully I can fix this with fluid, because fluid is a lot easier to excrete than dopamine. And if I have a patient with a history of high blood pressure, I don't want to be giving a medication that's difficult to excrete, like dopamine or dobutamine, because long-term that's really going to mess with their issue, their underlying issue. And just because they're hypotensive now doesn't mean they're going to be hypotensive tomorrow once I fix their volume issue. So again, that really gets into us as pre-hospital providers doing our due diligence and being a patient advocate for our patients with chronic issues. Okay? So anticoagulants, blood thinners, they slow the ability to clot. So a lot of times our patients have situations where they are going to clot a lot easier. Does anyone know the name of a dysrhythmia that's going to cause your patient to essentially have a milkshake in their heart? Go ahead, Dave. AFib, absolutely. Your atria just kind of, it doesn't even contract, it just fibs. It just shakes. So you have this atria just shaking, and it becomes a milkshake. It's not moving that blood, so it just becomes stagnant and it clots. And so these patients with chronic AFib have to be on some form of a blood thinner, because otherwise they're just going to make clots all day. So they're at an increased risk for stroke. So these patients have to be on anticoagulants constantly. Antiplatelet drugs are used to manage myocardial infarctions. They keep the platelets from sticking together and causing more damage. Okay, so a lot of times patients who have recently had a cath are going to come out and they're going to be on antiplatelets. So ask about that medical history as well. Ask about the medications. Are you new to this medication? Is this a medication you've been on for quite some time? When did you get this medication? Well, I recently got that medication when I had my most recent cath. Oh, okay. That's a whole other can of worms there. So medications with patients with cardiac or cardiovascular disease. Table 17 really gets into a lot of what we are going to see pre-hospitally. This isn't something that you're going to see on a test, but it's something you guys have to have a familiarity with, because again, when you start your clinical ride time and you start your time in the hospitals, you're going to start seeing patients with these long patient histories, and these are medications that you're going to want to know or have at least a vague idea of what they do, so that you guys can kind of start putting two and two together. So your secondary assessment, we've done our primary, we know our patient is stable-ish, we know that they need treatment, but they're not dying. So at this point, our secondary assessment is going to emphasize cardiac issues. What's their level of consciousness? Because level of consciousness is a huge indicator for cerebral perfusion. If they have a decreased level of consciousness, their cerebral perfusion pressure is going to be down, chances are. And if that's the case, what's causing that? Is it a cardiac issue? If they're alert and oriented, then they obviously have enough oxygen to function. But if they're in a stupor or they're really confused, probably we've got poor cardiac output. There's something going on where our brain is not getting the perfusion it needs. Look at the skin temperature, or skin color, and then feel from skin temperature, because they're going to be an indicator for circulatory issues. We want to look for a physical exam that is complete head to toe in these patients, because again, we're looking for any possible clues that we can find. We're looking for pupillary reaction. We're looking for skin tone on the face. We're looking for necks, for tracheal position. We're looking for jugular venous distension, because JVD is an indicator for what?
CHF.
It could be a late indicator, yeah, for CHF, but more importantly, it's an indicator for what? Beyond that, it's an indicator for what? Increased venous pressure. Everyone gets really caught up on which side of the heart that is, and realistically it doesn't matter. If you see JVD, then you're thinking an increase in venous pressure, period. All right? That's really important for you guys to understand, because again, when we see that, we know that this person is significantly ill. There's a lot of potential for this person to be really, really bad. We're going to inspect and palpate the chest. We're looking for surgical scars, nitro patches. We're looking for pacemakers. Pacemakers can also be in the abdomen. Really old school pacemakers, people who are elderly tend to still have them. They're like down by the rib almost. They're like right here in the abdomen. So it's not uncommon to not see anything up here in the chest, but then come down to the rib line and actually start to see these things. Chest, you're going to see like chest enlargement from chronic issues, and we're looking for crepitus, signs of crepitus. Listen with a stethoscope. You know, your book talks about heart sounds. It talks about the normal heart sounds of S1 and S2 and abnormal heart sounds of 3 and 4. And for us pre-hospitally, we tend not to really use those sounds as indicators because, again, our environments aren't controlled and we can't always control the external environment enough to hear what we're listening for. Even so, we need to be listening. We're listening for lung sounds, we're listening for our heart sounds, and we're trying to gather as much data as possible. Obviously, if we have rails, we're thinking what? Congestive heart failure of some kind. You know, if you have a patient who has a fever and they have really bad chest pain and you listen to their lungs and it's just really junky. Could be pneumonia. Could also be pericarditis. Okay, where the surrounding the sac of the heart is actually inflamed. Okay, and it's presenting itself in such a way that the person's having severe chest pain with a fever. And you put them on the monitor, a really big indicator or like a blatant, like big blinking sign for pericarditis. ST segment elevation everywhere. If you see ST segment elevation everywhere and they have a fever, it's pericarditis. Absolutely. Big indicator for that. So again, we get into the heart tones. In your notes, I kind of broke this down a lot. Take a look at it. It's not something that you're going to see on the test beyond your first web quiz, but it's something that you should be familiar with enough to kind of fudge your way through. Pre-hospitally, again, it's not something that we're going to do often because we just don't have the ability. When you are in your clinical settings, I want you guys to listen for this. I want you guys to learn on your patients. We don't always have ideal settings in field externships or pre-hospitally. But when you're in a hospital setting and you're in a clinical setting and you're up on the floors, you should be listening for these sounds. And you should be learning as much as you possibly can because these are ideal environments. So the S1 corresponds to carotid artery pulse. It's a decreased sound that it can indicate mitral valve. Sorry, guys. Mitral valve subject to fibrosis or is calcified. People who are obese tend to have an increase in S1 emphysema patients and cardiac tamponade. S2 correspond with pulmonary and aortic valve closing. It tends to be louder in people who have chronically high blood pressure or pulmonary hypertension. It can be decreased with people who have really low blood pressure chronically. S3 is caused by ventricular wall vibration. It occurs about 120 to 170 milliseconds after the S2. I know, it's stuff that, like, you know, they tell you, and it's just pre-hospital. We don't have the time. I'd like to tell you that this is something that you are going to use, and I'm sorry, it usually is not. S4 is heard just before S1. It's like a turbulent filling of stiff ventricular hypertrophy, possible myocardial infarction if you're hearing an S4. But again, by no means is this a definitive indicator. Other abnormal heart sounds: opening snap, ejection click, pericardial friction rub, a murmur, a thrill, and then pericardial knock. Again, in your notes, I kind of broke it down a little bit for you guys, but we're really just not going to use them. Look for during your physical exam, we're going to spend a lot of time on the pulse. Is it irregular? And if it is irregular, why is it irregular? Is it a disturbance in the cardiac rhythm? Is it rapid? And if it's rapid, what's causing it? Is it an anxiety issue? Is it secondary to severe pain or cardiac dysrhythmia? Is it a weak thread from a reduction in the cardiac output? Like, what is causing this issue? The pulse deficit. Radial pulse is less than the apical pulse rate. Okay, this is an issue. Pulsus paradoxus is an excessive drop in systolic blood pressure. Pulsus alternus, left ventricular systole damage. So again, these are things that we're looking for when we are feeling for a pulse. We have to know what these signs are and what they mean. When we're looking at our blood pressure, okay, we're looking for systolic blood pressure that's 120 to 130. That's going to cause, or that's going to be an indicator for us that someone is hypertensive. Diastolic blood pressure is 80 to 89. I'm going to tell you guys right now, every year, every time the AHA talks, these numbers get lower and lower for hypertension. They really do. They keep decreasing it. When I first started, it was like 140. Systolic was considered hypertensive, and now we're doing like 120. Every time they roll out something else, the blood pressure, the thresholds for hypertension just keep getting lower and lower. Elevated blood pressure can be caused by anxiety or pain. Systolic blood pressure lower than 90 is indicative of hypotension or shock. Increased pulse pressure can be caused by atherosclerosis. Reduced SV or stroke volume, cardiac shock, or cardiac tamponade. Monitoring. There's two different monitoring that we're going to do pre-hospitally. You got 3-lead tracing, which is 3 to 4 limb leads. And then you got your 12-lead EKG. Your 12-lead is obviously going to give you a much better picture of what you're looking at with the heart. Obviously, we're looking for waveform capnography. You can also use pulse ox if you so desire. I want to show you something really cool. And this is going to set you up for your 12 leads. All right, this is a very quick and easy way to remember. Damn it. This is a very quick and easy way.
That government, right?
I know, right? Always keeping me down. But again, this is a really quick and easy way to remember what ST segment means when you see it where. Each of these locations is a great way to just, if you see ST segment elevation in leads 2, 3, and AVF, it's indicative of an inferior wall MI. If you see ST segment elevation in leads that are contiguous, meaning they have to come one right after the other, V1 and V2, it's a septal wall MI. If you see ST segment elevation in V3 and V4, it's going to be an anterior wall MI. Leads V5 and V6 is going to be lateral. Okay, I see all leads. Easiest way I have ever come across to learn this stuff. And again, we're looking for ST segment in contiguous leads. 2 or more contiguous leads means that it's an MI. This is a great way to remember where the damage is. Okay? All right. So, Ian, I have a patient with ST segment elevation in V4 and V5. What does that mean?
Gonna say anterior lateral.
Yeah. See how that works? If you have something that kind of spans both, then we're thinking there's involvement in both sides of the heart. Kat, I have ST segment elevation in 2, 3, and AVF. Where is it? My guess, I have ST segment elevation in V5 and V6. Where is it? Chris, I have ST segment elevation in V3 and V4. Shram. V3 and V4. Sorry. Okay, cool. Larissa, I have ST segment elevation in V2 and V3.
Oh, septal atrial?
Yeah. I mean, see how easy this is, guys? This is not hard. Okay, this is not hard. Now, there's more to this, obviously, but this is the basics. We're going to start talking about reciprocal changes in just a couple days, okay? But this is your ST segment elevation. This is an easy way to remember this. Cardiology should not be hard. Cardiology should make sense. Don't let people psych you out. If you're starting to get freaked out, I actually can help you with this stuff. So come to me, okay? The AMP stuff is, but when we get into the heart, I'm a chick, okay? So listen, if you guys are starting to feel overwhelmed or frustrated, let us know. We can set up some tutor time. You know, I can send you stuff. I've got all kinds of really cool things that'll make this a little bit easier, like the ICL lead stuff. Let me know what I can do, all right? Does anyone have any questions from tonight? This is a lot of material in a short amount of time. Are we good? Because this is the foundation of what we're going to build on now. Cardiology is going to move fast. We put in extra padding time. You know, we have this additional time. But again, I need you guys to feel comfortable before you walk out that door tonight. How we doing? We okay? All right, good. Good, good, good. So 3 primary pacemakers of the heart. Larissa, what are they?
The SA node, the AV, and Purkinje fibers.
Okay, yeah, the junction, absolutely.
Junction.
Okay, how many pacemakers do you have in the heart, Mike S?
How many pacemakers?
How many pacemakers do you have in the heart? You actually have a lot more than 3, but you have 3 primary, right? Okay, good. Those other ones that are not really one of the big 3, what do we call them? Bob. Son of a bitch! She remembered I'm here.
I thought we were past one.
Someone else help him out.
Ectopic foci.
Ectopic foci. Ectopic foci. Good. Good, good, good. All right. Let's see here.
I didn't like that.
I know, it really just kind of got angry.
It's gonna get really angry because wasn't that opened off of the.
Yeah, that's why I took it out. All right, Ian, what's the normal rate? What's the intrinsic rate of the SA node?
60 to 100.
Okay, very good. Mike B, what's the intrinsic rate of the Purkinje fibers?
20 to 40.
Good. The P wave is what, Ed? P wave represents what?
Atrial depolarization.
Nice. Okay, the ST segment is elevated when we have what, Mayor? Potentially acute MI. Very good, very good. If I have ST segment elevation in V1 and V2, Brian, what do I have?
Septal.
Very nice, very nice. Okay, very cool.